right, so okay. I'm Michael Ritchie. If I haven't met anybody of you guys yet, there's like 100 of you guys. I'm going to do my talk on fluid resuscitation in the SID. Hopefully it'll be some like new stuff you haven't heard of, some things that you can potentially help out. If you have any questions, just interrupt me, because could be some stuff that could be a little bit confusing. Okay? So we're going to learn about fluid resuscitation, kind of a little bit of the evidence behind it, some things you want to do. We're talking about volume and mortality, as well as SID and mortality, and we'll go into that, and then we'll talk a little bit about where fluid resuscitation is going in the future and all that.
What's SID stand for?
We're going to get to it. So, differentiating shock. Obviously the first years, what are the 4 different types of shock? First years. Distributive. Obstructive. Hemorrhagic fits into a broader category.
Hypovolemic.
All right. So how do you treat obstructive shock in a broad sense?
Remove the obstruction.
Treat the underlying condition. How do you treat cardiogenic?
Help the heart. Support the heart.
Yeah, diuresis, inotropes, hypovolemic,
Volume.
So it's going to be isotonic fluids or blood, depending on what the cause is. And then the last one is distributive.
Peripheral vasopressors.
Fluids and vasopressors. So the idea is we're not going to talk about obstructive or cardiogenic. Don't need to talk about blood. So we're just going to be talking about fluid resuscitation. We're doing isotonic fluids, that type of stuff. And we're going to throw in a little bit about vasopressors. So case number 1, 62-year-old hypertension, diabetic, as you can see, cough, productive of sputum. Now he's tachycardic, hypotensive, febrile, tachypnic, meets criteria on multiple standpoints if you want to use SIRS or QSOFA. And what do you want to do for this person?
Get him on a monitor.
So treatment-wise, you're going to treat them as if they're sepsis, so early fluids, early antibiotics, source control. So everyone knows it's an easy one, pneumonia is going to be the thing, whether or not he has septic shock with it. And so everyone knows the stuff when we talk about which antibiotics, right? We get all the stuff that we talk about, we say, have they been in the hospital for the last 3 months? If they come from the community versus healthcare versus hospital. Everyone does that, but the question is, how much fluid do they need? Not how much fluid before you assess them for septic shock. That's 30 mLs per kg or whatever you do there. How much fluid do they need?
Depends on their
Right.
volume.
Yeah, so it really depends. And that's the question that I'm going to try to help answer is how much fluid and when do you want to give it? And then when do you start vasopressors? When's the best time?
I think as soon.
Immediately?
Probably not immediately, but probably sooner rather than later.
Yeah, next day?
They're
You have like
responding
a-
to fluids.
Probably after, if they don't respond to the first, bolus, you should already start thinking
It's
vasopressors.
like one bolus vasopressor.
I think it's going to depend, but I think probably after that first bolus, you should start thinking it at least.
So in critical care medicine, they had this article, 2014. They looked at 24 hospitals in 3 countries. This was retrospective, so you can kind of take it however you want to take it. But what they did was they said they looked at the first hour, hours 1 through 6, and then hours 6 through 24. And they looked at how much fluid they got. They divided it into low, middle, high in terms of volume replacement for all 3. And those are the numbers. You can see they vary pretty extensively. And then vasopressors along the same one, early, intermediate, and late. So if you do the math on the number of different combinations you can do, it's 81 different combinations. And so all they did was they looked back and they looked at all 81 of these combinations and they said who had the best mortality and who had the worst mortality. So we had 2,849 patients and they had it looked all the way across the board and they said who did well. So these are the people that did well. As you can see, a lot of people with high, medium, early up fluids, including coming into the 1 to 6 hours. Maybe not as much as you see in the 6 to 24, but you can see intermediate for the vasoactive seems to be pretty strong through there, the 1 to 6 hours for the vasopressors. And then you look at the 10 combinations with the highest mortality. And you can start seeing that early vasoactive, late vasoactive kind of really overtakes that whenever it talks about the highest mortality. And you start seeing more of these kind of lower fluids in here. And so their conclusions were that patients with kind of an early, middle to high volume. Yeah.
The only thing that's weird about that is sicker patients are going to get pressors earlier.
Right.
So they're going to have higher mortality because they're sicker.
Not necessarily. So they're looking back on it. So yeah, so you have people that are sicker, but so you would say maybe they started pressors earlier. Is that what you're saying, or they got?
Yeah, the patients who are more critically ill,
Selection
closer
bias.
to death already, are going to be more likely to start pressors early because you're throwing everything at them. They're already quite ill.
Well, I would say most of the time. If you have somebody that's pretty sick, you still usually get pressors within the first hour.
If you're done, well, you'll be going on this.
But I'm just like usually within the first hour you'll get your 1 to 2 liters in and say, hey, they're not responding. So I would say rarely are people getting pressors in within the first hour. But the question was should we, right? Should we be getting them on the first hour? Should that be one of the first things we give? And there's certainly some people that say yes, we should be giving a lot less fluid, and then we should be giving pressors very, very early. Kind of this one said probably 1 to 6 hour mark was fine as long as you can do it. And then the later that is, they probably don't do well, is that you want to get the pressors on at an early time. You just don't want to immediately do it. And so the thought process is when you have sepsis, you have your vessels and they dilate and they get leaky, right? Glycocalyx, and they start getting all these holes and get very porous, and you start third spacing. And so you drop your intravascular volume. And so what the thinking is that if you put vasopressors on it early, is that you're shrinking something that's already intravascular depleted. You need to fill up the tank before you squeeze it down. So you have to give something up front. So don't immediately, it's not like as soon as they step in the door and they're hypotensive, go ahead and start putting them on some peripheral levophed, is that you want to tank up the patient just a little bit. Now that's not 7, 8, 9 liters, but it's enough that whenever you squeeze it down, that you're at least putting something. That's the thinking behind it. So I would say fluid in the first 6 hours is great, which is great for us because we're in the emergency department. Very rarely are we holding on to these people for 2 days. They could be down there for 2 days, but we're not holding on to them for necessarily 2 days. So yeah, fluid is probably great. But then the question is too much fluid bad? And that's kind of what I wanted to talk to on this, is that like we're very good about putting fluids on, but when is enough? And should we care in the emergency department? It's a huge thing in the ICU, but should we care in the emergency department? So there's all these papers that have come out in the last couple of years, and this is just a small things of it. Worse outcomes with higher hypervolemia. Fluid resuscitation, positive fluid balance leads to worsening shock, worsening kidney injury. Fluid therapy, less is more. The Fanaki study that showed increased mortality. So yeah, the data is all out there that says if you have a positive fluid balance during your stay, you have an increased mortality. So it's a big deal whenever we start resuscitating these people, that we resuscitate them appropriately. Everyone's seen this patient if you worked in the ICU. The patient that you're still giving fluids to because they're intravascularly deplete, but extravascularly fluid overloaded. So just keep giving them fluids; it'll eventually come together. So I want to talk about what you're kind of doing. So the skin you can actually see, right? It keeps getting bigger and bigger. You end up with pitting edema. But it's not like the fluid just goes to the skin. You can imagine it going to every single organ. They've now come out showing that a CBP greater than 8 increases your mortality. And it used to be this is what you titrated fluids to. You would put in a central line and you would say, listen, just keep giving them fluids until that hits 12 and wake me up if it doesn't, like that type of thing. And now they're showing that that's not necessarily the case, is that you want to give them a lot less fluids. So you get, in the lung, you get pulmonary edema. When you get pulmonary edema, you have decreased oxygenation, your PF ratio goes down, you're going to have a lot of issues in these people that can end up getting intubated. In terms of the chest wall, if you can imagine, every liter you give them is 2.2 pounds. And so you can imagine all of that weight of their skin and all of them just collapsing down their chest. They get chest wall compliance issues, and it can be difficult for them to expand their chest with all that added weight. Myocardial edema does happen as well, and you can get decreased contractility as well as some issues there. Abdominal compartment syndrome is huge, so you can imagine all that stuff going into the abdomen, and it actually is pushing up your diaphragm, and it leads to decreased lung volumes, as well as you're compressing your IVC, your intestines, your bladder, and you end up having a lot of problems there. You get ileus, malabsorption, so all those people that you're like, hey, we can't really feed them because it looks like they're having high residuals, they have an ileus, and maybe because you have them so full of fluid that they can't do anything with it. And then decreased wound healing as well, which is important in the SICU on all these patients, these trauma patients that we're trying to resuscitate as well. And then in hemodynamics, this is something I could have a whole conversation with. But the idea is that if you have such high venous pressures that your kidneys stop working because they don't have a gradient across their glomerulus anymore because their venous side is so high. But that's a whole other talk I could do. So just be aware when you're resuscitating somebody and how much you're giving somebody is that you have a lot of fluids that aren't those boluses that you're giving somebody. So every time you give vanc, it's 250 or 500 mLs. Every time you replace somebody's FOS, if you do it IV, if you have to give it a lot, that's about 500 mLs. Depending on your pressor concentration. So sometimes they'll mix 4 milligrams in, and sometimes they'll do like 16 milligrams of the levofed, and so it's a huge difference in the amount of concentration you're giving somebody. So you have high pressure requirements, you may want to concentrate that down. All right, so the other one is what if they're NPO? And people love to say, hey, they didn't eat for like 30 minutes, so we have to put them on D5 half normal saline. That's what we have to do. We need to do it. It needs to be done. So what's a normal one they put it on? A normal amount, anything? 125. Yeah, 125. Everyone loves to put people on D5 half normal. Anybody that comes in. All right, so does anybody know the math? They say, why do you want to give them? It's like, well, they're not eating. They're going to get dehydrated. They need all that glucose. That's why we're doing the D5. So how much fluid is that in 24 hours? Do the math on that. 3 liters. It's a lot of fluid, of salty fluid that you're giving somebody through an IV. Do you know how much sugar that comes with? You guys know how to do percentage math on that? Alright, so D5, 5% dextrose. The percent comes from that 1 gram of whatever you're giving in 1 gram of water. And water, 1 gram is 1 cubic centimeter or 1 millimeter. So it's 1 gram of dextrose and 100 mLs of water. So 1 liter. If 5%, you have 5 grams and 100 mLs, so you have 50 grams in a liter. So you're giving them about 150 grams of sugar in 3 liters. So you'd be much better off if you just gave them 3 Mountain Dews. You'd have a lot less fluid, a lot more sugar. You'd be way better off to be able to do that. And so they actually just came out with a paper this year that talked just about that in trauma patients, that if you reduce their rate to just 30 mLs of this maintenance fluid that everyone wants to put it on, you have decreased ventilator days, decreased ICU days, and improved morbidity, mortality, whatever you do. So it's something you want to think about, that just because they're not eating, is that, and this is what they looked at, they looked at people that were normotensive trauma patients. If your patient is hypotensive and you think they're legitimately getting dehydrated, fine. I think that's reasonable, but just because they're not eating doesn't mean they need 3 liters of hypotonic fluid. All right, so how do you assess fluid status? And this is a whole other talk, so I'm not going to quiz you guys on it, but the whole idea behind it is that everyone sits on this Starling curve, and that the idea is that as you give them volume, that their cardiac output goes up. And this is what you want to do. They're hypotensive. You give them volume. They go up on this curve until they don't go up on the curve. And that's whenever they kind of max out on their Starling curve. And so everything we do is we're going to say, hey, are they responding to fluid? Which says, are they getting an improvement in their cardiac output as we give them fluid? So there's many different ways we can do it. Passive leg raise. We give them their own little bolus. If you look at the paper, the only correct way to do it is if you do it this way. Is where you actually have the bed come up this way. And since none of our beds actually do this, it's going to be very difficult to appropriately do it. You can kind of say, hey, I'm going to lift their legs up and see what happens. But for a lot of people, that's good.
Turn on the bed.
Can we put it backwards in the bed?
Just put them backwards.
Just flip them back. And then you have to have them sitting up first. You're going to have to like put them up and flip them up. There's a lot of flaws.
Make sure you call your RTs.
And then, but like these people are probably already like, if they have a lot of fluid on board anyway, if you've ever lifted anybody's legs up, they like scream out in pain and act like they've never lifted their legs up. And if their blood pressure goes up, who knows why their blood pressure went up? Was it because they were in pain, or was it because they got their 500 ml bolus and they need some fluid? So I think it's very hard to do this reliably in the emergency department. Our favorite one, everyone loves to put the ultrasound on their IVC. Ideally, you want to be able to look at the hepatic vein whenever it comes in. You want to measure it. Some people like M mode. Some people have a certain percentage they look at. Basically, if you're having variations in your IVC with respiration, means that your IVC can collapse and that you're getting decreases in your preload. So if you're getting decreases in your preload with respiration, then that means that you can probably respond to fluid because it's able to decrease your preload with respiration. Same idea as if you put it in an arterial line, is that when you breathe in and then you breathe out and you're collapsing your IVC, you're going to look at the area under the curve of your A-line, or you can just look at the amplitude. And if your amplitude varies, then that means you're probably fluid responsive because you're having variations with your breathing. Another thing you can look at, which people want to really look at, is that you're actually going to do serial cardiac outputs. So you look at your aortic diameter, and then you look at your LVOT VTI, which is your velocity time integral, and you're going to look at the area under the curve, and you're going to figure out you have you do pi r squared, and you have your area, and you have your area under the curve, and you end up getting a stroke volume times heart rate equals cardiac output. So you get a cardiac output, you give them fluids, and then you repeat the cardiac output and see if it went up. That's fairly extensive to be doing on a regular basis on these, but it's something that if you get good at, it's something reasonable because you don't have to change, you don't have to keep looking at the aortic diameter because it's not going to change. So you're just going to be doing continuous VTIs after you do an intervention.
It's almost like do the math for you. You just have to know how to do the math.
And you have to do that, yeah. The computer does the stuff for you. You just have to know how to do the measurements on it. So again, this is all that you're trying to do is you're trying to get them up on this curve. So if you can't get them up on the curve with fluids, then that's when you start adding things like vasopressors and inotropy and those things. All right, so how much fluid is the right amount of fluid? What do we come up with the answer?
4 liters.
The answer is it 1 liter, is it 3 liters, or is it like a fire hose? You just give them whatever you can get as fast as you can. The answer is the exact amount they need. People say this all the time. People love to quote this, say that's the exact amount they need is the amount of fluid they need. Of interest, back in the day, we participated in this hospital in the process study, and we showed that it wasn't really any better with anything. But if you look at Rivers with this early goal-directed therapy, and you look at ours, he had the really, really high mortalities. I'm not saying that they're related. I'm just saying that we're doing a much better job of not fluid overloading these people. At 72 hours, most of the people in their study were 13 liters up. That's 26, 20, close to 30 pounds maybe. It's pretty solid. We halved that in the studies, and if you look at the other ones, it was even probably lower in the other studies as well. And so we're doing a much better job of that, and it could have something to do with the lower mortality, although it wasn't really looked at when we did that. So does the type of fluid matter, right? We only have 2 options down in our emergency department, but everyone gets normal saline, and the surgeons give lactated ringer, and that's about it.
Yeah, plasma.
They what?
They have the balance cell solutions.
So crystalloids and colloids, right? No one's using head of starch since I was an intern. So we have albumin from the colloid standpoint. Crystalloids, we have our isotonic, hypotonic. Hypertonic is actually getting really big if you want to talk about it in heart failure as well as sepsis, something that you can talk about later. Is that's going to definitely stay intravascular when you give somebody 3%, but that's a whole other conversation. But these are kind of our options with the isotonic. And the question is, does it matter what you give whenever you're doing this? So you have a 35-year-old who comes in, type 1 diabetic, ran out of his medications, not taking them. Now he's having all the signs that he has DKA. So hypotensive tachycardic, tachypnics, kind of some Kussmaul respirations, ill appearing. What do you want to do? Great. Fluids. We'll get some labs, and then depending on what the potassium is, you can either start the insulin drip now if he's hyperkalemic, and then if he's normal to low, you should probably replace potassium before you give it because it could lead to hypokalemia. So you guys do that. You're in CCT. You're really excited. You put in like 2 16 gauges. You're high-fiving your friends. You gave like 6 liters. They just flew in because of everything. And then you get the labs just as you suspected. They had DKA, gap at 20. You're like, you know what? I'm going to close this. I don't even need to call ICU. So you're spending your whole day in CCT. You're giving fluids. And then you go to check it, anion gap at 8. Right as rounds end, you're high-fiving your friends, you go home, tell everybody how great you are. Downgrade to the floor. So here's the labs start coming back after you see the anion gap at 8. So you have a sodium of 141 and a chloride of 16. What do you guys think about that? Use the math, gap at 8. Sorry, we'll go to the next slide. So the labs, everything comes back. 7.25, yes, bicarb has gone from 15 to 17, great job. They now have a gap of 8. Their sugars have come down to 250. Potassium's basically at normal now. Are you guys excited about this?
No.
No. So what happened?
Too much chloride in fluids.
Too much chloride in the fluid. Does it matter?
Yeah.
It does matter? Okay. So is hyperchloremia bad, right? So this was something we give every day. We're giving somebody that normally has a chloride of 100, we're giving a chloride of 151 or 154. So increased kidney injury with hyperchloremia, hyperchloremia in hospital mortality is a connection. Saline should not be your first choice in resuscitation fluids. Hyperchloremia associated with mortality. Hyperchloremia after non-cardiac surgery, independently associated with increased morbidity and mortality. Clearly, hyperchloremia not great.
2 years ago, I think it was maybe there was a study that came out, it was like osmolate versus NS and DKA. And they were discussing which one was better, and everyone was super excited because osmolate was going to show to be better, and they found that there wasn't a difference. Do you remember that study?
I don't remember that study, but I think that you'll. I think it depends. It's going to depend on the person and how the person handles it. So if you have somebody that is extremely dry and you gave them 8 liters of normal saline versus you gave 4 liters of each, it may just be there's not enough to tell a difference.
Okay.
So I'm going to talk about the Stewart method of acid-base. This is the whole thing. We're going to talk about acid-base physiology. We're going to talk about independent variables, dependent variables, and then how fluids alter your body so you can get a better idea of what you're giving people whenever you give it. All right, so most people when they talk about acid-base, they do Henderson, Hasselbalch, they do this whole thing. That works fine for most things. But the question is, how does giving 2 liters of normal saline affect someone's pH?
Causes acidosis.
Does it? How do you explain it with the Henderson, Hasselbalch?
I think you explained it with the SID.
Yeah, so you explain it with the SID. It's a much better explanation whenever you're looking at things that cause some issues, whenever you look at the strong ion difference. And so the idea behind this, is that we have independent variables, which are variables that change whenever you are acted on by the outside of the body. So carbon dioxide is determined on our ventilation and stuff, and our body can't change the amount that we have. We can try to buffer it and stuff, but it can't change the amount we have. It's just based on what our lungs are and with our ventilation and everything. Total weak acids, there's the three major ones are albumin, inorganic phosphate, and bicarb. Bicarb is not considered an independent variable since we can make it. But the albumin and the phosphate come together and they form what's called total ATOT, which is your total weak acid, which does not include the bicarb. And then you have your strong ions. Your strong ions are your strong acids that completely dissociate. Weak acids don't completely dissociate, they go back and forth. It's all from chemistry or one of those classes back then. Whereas all the other ones completely dissociate. So they're the ones that are driving everything because they're your strong acids. So your body responds to your changes in your strong acids. So those are your anion gap is actually your unmeasured anions, minus your bicarb, which is just your albumin and your inorganic phosphate. And normally your phosphate is too low to really matter at those levels. So it's just your albumin, which is about 2.5 to 3 per albumin. And that's why most people's gap is 8 to 12. So if somebody has an albumin of 2, then they're going to have a gap of 5 or 6. So their normal anion gap of somebody with an albumin of 2 is 5 or 6, as opposed to somebody that has it. So whenever you're looking for your, if somebody has an anion gap and they have an albumin of 2 and their gap is 13, they have a gap because their normal gap is significantly lower. Does that make sense? Another way people do it is they say, hey, for every albumin less than 4, then you need to add 2.5 to your gap to correct for the gap with your albumin. That's another way people do it. You just don't miss that people will have a gap if they have a low albumin. A gap of 12 is not normal in somebody that's with. So the dependent variables are going to be your hydrogen ions and your bicarb ions. And the idea behind this is that your body can make these. When you have too many anions, which are your chloride, your body responds by generating more hydrogen ions and you become acidotic. If you have more sodium, then your body responds, it's a cation, your body responds by generating bicarb and you become more alkalotic. Because hydrogen ions and bicarb can be generated by the body, that's why they're dependent variables. And we can make an unlimited supply. It's just the way that we do it with it. So what are some ways we can do it? One of the major ways is our hemoglobin. It does a really good job, is it actually can bind hydrogen in a separate place than it binds oxygen. So whenever it binds hydrogen, it releases the oxygen. Whenever it binds oxygen, it releases the hydrogen. But it can do a good job of buffering and creating the hydrogen or bicarb that you need. So if it binds a lot of the hydrogen, it's going to be able to free up a lot of bicarb to improve there. Or if you need the hydrogen ions, it will release the hydrogen ions whenever it needs. This is the Bohr model that talks about all that type of stuff back in the day. All right, so it's the law of conservation of charge. So instead of saying, hey, we're going to do the anion gap, we're actually going to do the strong ion difference. And that's all of your strong ions, cations minus your strong anions. So these are your strong cations, and these are your strong anions. They usually don't mention these, but if you look it up, it ends up being lactate, acetoacetate, beta-hydroxybutyrate, and sulfate. And we all have a little bit of that in our body. We just don't measure it on a regular basis. So when you add these and subtract it from the addition of these, it's about 40 to 44. And that's going to be the difference between your strong ions. And that's where you're going to come in to set, these are your weak acids with your bicarb. So it's the ATOT plus bicarb equals your strong ion difference. So it's these things. It's going to be your difference, your 40 to 44. To make it easy, we're just going to use the two major ones, the ones with the highest concentration. All these things are fairly low with all these. As you can say, it's just going to be the difference between your sodium and your chloride. So your sodium normally is 140, your chloride is around 102. A normal SID should be around 38. Is this making sense for anybody? Okay. So anything that deviates from this is either going to make the person more alkalotic or make the person more acidotic. So if the SID decreases less than 38, That means you have a hyperchloremic state, your body responds by getting more hydrogen ions, you become more acidotic. If your number is greater than 38, you have a higher sodium or a lower chloride, and your body responds by making more bicarb.
For the math in this, are you correcting sodium to glucose? Or you just leaving?
No, they do it on both. Yeah. So here's an example on some small amounts of fluid. So if you could have somebody that if you have 1 liter of plasma, which obviously we don't have, and you give them 1 liter of normal saline and they were to stay both intravascular, then you would have 2 liters now, and the resulting SID would be 19, which is very acidotic. Yeah, just average between the two. So you look at it on a large scale on somebody, is that you look at somebody when you look at their extracellular fluid, you have a sodium of 140, chloride of 100 to make it easier, so they have a SID of 40, and then you look at somebody, and then you look at have like 15 liters of extracellular fluid, and then you go across and you say, if I added 3 liters of normal saline, that's 462 sodium, 462 chloride. That's barely going to increase your sodium just to 142.3. It's going to significantly increase your chloride from 100 to 109, and you've now changed your SID to 33. So you can see how the more fluid resuscitation you give somebody, the more acidotic you're making them. So it's not benign whenever we're saying, just hang 1 more liter, just hang 1 more liter. So any fluid, this is the main concept, any fluid that lowers the patient's SID will lead to a lower pH. Anyone that increases the SID, makes it wider, it's going to make the pH higher. So giving a patient a fluid with a lower SID or a higher SID will also be able to change it because you're going to change the plasma and you're going to result in acidosis or alkalosis. Now, this is fine for you guys to remember and to do it this way. A little wrinkle in this is that as you add fluid, that you're diluting out the A top, which is mainly the albumin, and you actually make them a little bit alkalotic because you're diluting out their weak acids. So if you give somebody with a SID, a fluid, an isotonic fluid, that exactly matches the patient's, it's actually not going to equal it out because you're actually diluting out their albumin a little bit. So here's some ones that we use. Normal saline we have, lactated ringers we have, and then Plasmolite, Normasol, Isolite, all these ones that we have upstairs are kind of around this area. So normal saline has 0 SID, has an equal number of sodium and chloride. Lactated ringers has lactate, and then we have the Plasmolite Normasol has some combination of usually acetate and gluconate. And those are going to be what makes the difference so that you have some sort of a SID. Theirs is a little bit alkalotic at 49. This one's a little bit acidotic at 28. All of these things, the lactate, the gluconate, the acetate, the citrate that are in a lot of the things that you give them, end up going down one of these pathways and end up in the TCA cycle, and you end up with CO2 and bicarb and ends up going to bicarb. So that's the argument saying you give somebody lactated ringer, you're going to end up with bicarb. If you give somebody acetate, you're going to end up getting all the way down there, you're going to end up with bicarb. Same thing with citrate as it goes in. Gluconate, also they say do that, but no one's been able to actually find a pathway that makes gluconate do anything. So they feel like a lot of it